morning, everyone. So I'm not sure how this looks, but I tried my best to put this on for Janice. Okay. So we're going to move on to the Stu Wilson Historical Lecture. This lecture is supported by the AAS Foundation and many of you and others who pledged or donated to support it. Your contributions to the AAS Foundation go towards programs and research to help support the members and to work towards improving the science and art of endocrine surgery. At this time, I would like to introduce our speaker, Dr. Janice Pasieka. Dr. Pasieka was trained in Calgary, where she was resident. But after that, she became interested in endocrine surgery. At the time, endocrine surgery really didn't have any fellowships, so she decided to train some more. And she trained for 2.5 extra years, spending time in Calgary. She then went to Michigan and spent time with Norm Thompson. And then she went further to go to the Karolinska Institute and spend time with Bertil Hamburger, an expert in neuroendocrine pathology and surgical pathology. She has dedicated her life work to the care of endocrine patients and, frankly, to this organization. In Calgary, she developed a multidisciplinary clinic for neuroendocrine tumors and hereditary endocrine tumors, which stands today. She established the AAS accredited fellowship in Calgary and has gone on to train numerous endocrine surgeons throughout the world. As a citywide division chief of general surgery, she worked, as she always does, so when she finds a problem, she works towards improving it, so improve the coverage of call coverage, and is now a model in Canada. She has recently been awarded the Outstanding Clinical Research Award and the Lifetime Achievement Award from the Department of Surgery. She was named Canada's most powerful women, and I don't know where she ranked, but I'm sure she was top. Dr. Pasieka served as Secretary-Treasurer of the AAS, and in 2010, she became the first Canadian and second woman to lead this organization. And I know Janice actually modified as Secretary-Treasurer, which is the hardest job in this organization, by the way. I remember she revamped the whole book. Nevertheless, she also has served in the IAS and is now president-elect of that organization. Dr. Pasieka was also awarded the Oliver Cope Meritorious Achievement Award, which is the highest award we give in this organization, and she, of course, was the first woman to receive it. So she has numerous interests outside, including mountain biking, running, cycling, and she has a dog named Coker. I want to just say that she is a true scholar and has numerous publications and has done many things. I recall also she was the editor of the World Journal of Surgery, or an associate editor, and I got numerous reviews to do for her, so I remember you fondly for that. Thank you. And on a personal note, Janice, as I said yesterday, I have always looked up to you, as I have done with many trailblazer women in this organization. So thank you very much for improving the path for those behind, like me. So let's welcome Dr. Pasieka. So I asked her to talk about pancreatic neuroendocrine tumors with a historical note, so thank you, Janice, for putting up with that. Hopefully, it wasn't too much work.
Well, thank you, Carmen. I have to stand to the side of the podium, as you know, because I can't see the slides otherwise. Are my slides going to come up? Do I push this? No? Perfect. Yep, super. Thank you. Could you put the main screen on just as a slide? I don't have any notes on my talk. Well, first of all, thank you very much. It really is an honor and a pleasure to be able to give the Stuart Wilson Historical Lecture. I have no conflicts of interest, and I will say from the outset that there is no part of this talk that has been done with artificial intelligence. Now, when Carmen called me back last summer and asked me to give the historical lecture, I remember it very well. I was sitting in the backyard and I just broke out laughing because I remember very distinctly some sage advice from Professor Delbridge. And when he told me, he said, Jan, when they start asking you to give a historical lecture, it's time to retire. And I went, oh my God, is this an omen? Is this a sign? I mean, I've always taken this man very seriously. So as I was packing up my office, I came across this picture, and this great picture of Stu Wilson. This is at our Banff meeting in 2002. And the man in the foreground is Professor Delbridge. And the best I can figure out what's going on, he's trying to figure out how to make a phone call on that disposable camera he just bought. So then I went, I don't know, should I have taken this guy's advice seriously? But I do know we can take this man's advice seriously. Theodore Bilroth said, only the person who is familiar with the art and science of the past is competent to aid in the progress in the future. And that is why we give historical lectures at societies like this, to reflect on the past. And so I'm going to talk about pancreatic neuroendocrine tumors and the surgical endocrinologist, learning the history to preserve the legacy. Now, I'm going to apologize to my international colleagues, and I know all my fellows are going, no, never apologize about your slides. I am not apologizing about my slides. I'm apologizing to the international colleagues, because when Carmen asked me to do this talk, she said, could you weave in and focus on the importance that AAES surgeons played in the discovery and the history of neuroendocrine tumors. So my talk is going to be very North American centric, and I recognize that a lot of things were happening at the same time in Europe and other places in the world, and if this talk was given in Europe, maybe the players in my story that I'm going to talk about would be a little different. I also then had the opportunity to spend some time talking to Dr. Wilson, and we had a lovely conversation, and he gave me several clinical vignettes that I hope to weave through this talk. But when I hung up the phone and I looked at my notes, there were a couple of things that really stood out for me. One of the first things he talked about, he says, Janice, you know, in his time, surgeons really had long-term clinical follow-up and observation. He said, once you operated on a patient, that was your patient for life. You followed them through the whole course and journey of their disease. And that also many of the surgeons that were academic were really focusing on the physiology of the GI tract. He also said it was at a time that there was some great collaborations, that the endocrinologists were very excited to collaborate with a group of surgeons that had taken up the cause of dealing with endocrine surgical diseases. So my learning objectives for you today are twofold. First, I hope to be able to illustrate the important role that surgical endocrinologists play in the discovery and our current understanding of functional pancreatic neuroendocrine tumors. As an endocrine surgeon, you have a unique expertise, and you need to utilize that expertise when you go back and take care of your patients at your institution. I also hope that I will be able to show you and identify the value of collaborating with other disciplines outside of surgery to expand your knowledge in endocrine surgery. Go back and evaluate how often you're doing that. So, it's a historical lecture, so we're going to go back in time. We're going to go back before Facebook, YouTube, Twitter, artificial intelligence. As a matter of fact, we're going to go back before the first MRI scan. The First MRI scan done in this country was in 1982 and really didn't come into play until the 90s. The first CT scan was in 1971, so it wasn't until the mid-80s that most institutions actually had a CT scan. Appendicitis was made by examining the patient. Before the AAES was even born, before internet, did you know that email only came into the play in 1985? But most importantly, before radioimmunoassays, because it's this technology of radioimmunoassays that allows us to then measure hormones and peptides that we take for granted now in the workup of functioning pancreatic neuroendocrine tumors. So we're really going to go back to the birth of endocrinology. In 1855, Bernard was the first to talk about this internal secretion. He recognized that something was being secreted that had a physiological effect on humans. And it was in 1905 that Bayliss and Starling really identified what they called a chemical messenger, secretin, that stimulated pancreatic secretions. And they then used the term hormone, which from the Greek derivative means to excite. And then we then moved into, I think it was Starling that then coined the term endocrine and endocrinology, which really was a new principle in physiology in 1914. Now at first, we were able to recognize hypofunctioning states, like Coker and hypothyroidism, like Addison's disease. But then eventually they started recognizing there could be over-secretion of these internal secretions. So we're going to look specifically at functioning pancreatic neuroendocrine tumors. And the column on the left shows all of the hormones and peptides, insulin, gastrin, VIP. And then the next column is the physiology. So when in the literature we started to understand that there was a chemical messenger that was changing things. And you know, the story of the insulinoma followed a very linear path. 1908, they knew that it had there was some messenger that regulated our glucose. But it wasn't until 1922 that we actually isolated insulin. And then it was several years later before somebody was able to put together the pieces that there was a tumor that overproduced insulin, and we had the insulinoma story. And that's long before you could actually measure insulin in the blood. But look at Zollinger-Ellison syndrome. The syndrome's described in 1955, 5 years before they even isolated gastrin. And then the Werner Morrison story is, the functioning syndrome was described before we even knew the physiology of VIP. And then the glucagon and the somatostatin, we had to measure these peptides and hormones first, and then put them into what the syndrome was. So what I want to do is us to then dive deep into the islet of the pancreas. So let's start with the first one, the insulinoma. So what do these gentlemen have to do with the whole insulinoma story? So in 1889, Mikowski was actually the surgeon, and they found that you could develop diabetes if you took out the pancreas in dogs. And that Mikowski then realized, well, if I retransplant a portion of the pancreas back, I can mitigate that effect. And so now all of a sudden we knew the pancreas had something to do with glucose metabolism. And it was in 1893 that Languise then said the internal secretion that mediates glucose metabolism is coming from the islets. And so between 1908 and 1920, there was a lot of work done on crude pancreatic extracts, grinding up the pancreas and injecting it back in with some hit and miss effects on decreasing one's glucose. It was in 1921 that Palusko wrote about what crude pancreatic extract that he had, which he called pancreatin, and showed that it decreased glucose in pancreatectomized dogs. But really, it didn't get as much notice compared to the next two, and that was Banting and Best. Banting was a surgeon. He actually was working at that time in my alma mater at Western, and he came up with this idea that what we needed is a pancreatic extract that was really based just on the islets. And so if we ligated the pancreatic duct, the acinar cells would involute and then take that and make this pancreatic extract. Now, he wasn't a scientist, so he went to the University of Toronto and met up with MacLeod, who is the head of physiology. And MacLeod thought, yeah, this is a good idea, gave him a lab to work in, and the use of a medical student, Charles Best, the man on the left. And so watch how quickly things happen. So Banting and Best started their experiments in May of 1921. And by August of that year, dog number 92, pictured here, Marjorie, lived for 20 days, and they knew that they were on to something. But unfortunately, the extract that they had had to be purified. So MacLeod brought in Bertram Collop from the University of Alberta, who was a biochemist who then set out to purify their extract, which they entitled islatin. Now, the other gentleman, Gilchrist, became an important part of this story. He was actually a medical student with Banting, and he had diabetes. So when they went into human trials, which started in November of 1921, he insisted on being part of that. And at that time, they would just inject it. They're not quite sure, how do we regulate this? And Gilchrist was able to then document what it felt like when you had too much insulin and were developing hyperinsulinemia. So that got documented. A year later, just 1 year later, this landmark article gets presented at the American Academy of Physicians on the effects of diabetes from this pancreatic extract. And then all of a sudden, insulin is now changing the life and well-being of patients with a devastating disease. And by December of 1923, Banting and MacLeod are awarded the Nobel Prize for this discovery. Banting shares it with Best, and MacLeod shares his prize with Collop. Banting became the first Canadian to win the Nobel Prize, something that we're very proud of. He is the 5th surgeon to win the Nobel Prize. There's 11 to date, if you're counting. And he remains the youngest Nobel laureate in the field of physiology and medicine at the age of 32. Now, this gentleman, Cyril Harris, from the University of Alabama, went up to Toronto to learn about insulin and diabetes, and then he went back to the University of Alabama. And then he wrote this very provocative paper because he then recalled and reported on 5 patients that he could demonstrate they had spontaneous hypoglycemia and all of these symptoms. Still can't measure insulin, remember. And he postulated that there must be an overproduction of the islets, not just an underproduction that we see in diabetes. And then we have these 3 physicians that then brought into the picture of the insulinoma. Dr. Wheelock was an orthopedic surgeon in the Midwest, and Dr. Wheelock was suffering. He was suffering from bouts of confusion, irritability, and at first people just thought he was a little off. Some of them, sometimes they thought he had an alcoholic problem, and he went to various centers, and nobody could figure out what was going on with him. His operating room nurse knew that if the slate was running late, to make sure that she fed him through the day or he wouldn't be able to get through his cases. Eventually, he was referred to the Mayo Clinic, and this was Dr. Weidler. Weidler was the endocrinologist that was taking on the task of developing the diabetes clinic at the Mayo Clinic. And Weidler brought him into hospital and did lots of studies on him and proved that he was having these bouts of hypoglycemia, and they're happening more and more frequently, and he struggled. He struggled to prevent these from happening. So he did what any good endocrinologist would do when you're perplexed with a patient. You refer them to your best surgeon. And so he referred him to Will Mayo, who then operated on him, found that he had metastatic pancreatic islet cell tumor. He had it in the liver. He took a biopsy of that, and subsequently the extracts from that biopsy produced hypoglycemia in rabbits, proving the concept that this tumor was producing insulin, even though you couldn't measure insulin. So then people got operated on if they had these symptoms of hypoglycemia. And it's hard to know if all of them actually had exogenous insulin. But a whole host of surgeons started doing the operation, and it was Roscoe Graham in 1929, yes, Graham of the Graham patch fame. He was from the University of Toronto, but he was the first to go in and enucleate a small insulinoma. So all of a sudden we knew that it wasn't just metastatic islet cell tumor that was causing this, there was benign condition that would do it. Everett Graham from Washington University, he went in to operate on a patient and he couldn't find the tumor. And so he did a subtotal pancreatectomy, and on the specimen, they found a 5 mm insulinoma. So now we know they could be very small tumors, but causing a devastating clinical syndrome. So what was happening then, patients were being operated on, but the accuracy of finding the tumor in somebody that you diagnose with this hypoglycemic syndrome was only 32%. And that's until Whipple and France put together a series of 32 patients that had islet cell tumors and this hypoglycemic clinical scenario preoperatively, and came up with that Whipple's triad, a triad that we clinically still use today in distinguishing patients with insulinoma. And that increased the accuracy of the surgeon going in, if you had Whipple's triad, from 32% to as high as 65%. So the Mayo Clinic became a real center for insulinomas, and this is James Priestley, who then published the first large series in North America of their patients, 154 patients, and they had an 86% cure rate before you could measure insulin, before you had any preoperative imaging. And he describes in his paper that bimanual palpation of the head, the neck, the body of the pancreas that some of us were taught as fellows. He also advocated for blind distal pancreatectomy when you couldn't find the tumor, even though only 42% of the time was it actually found in the specimen afterwards. This series then got updated in 1979 by John Van Heerden and Tony Edis. John Van Heerden, a former president of this society. And this is the only picture I could find of Tony Edis. There he is sitting at the table on a panel at the very first AAES meeting held in Ann Arbor, Michigan. And each and every one of the gentlemen at this table, Norm Thompson, Jack Monchak, Orlo Clark, and Ed Kaplan, all went on to write about and study patients with pancreatic neuroendocrine tumors. The other gentleman is John Service. He's the endocrinologist that worked closely with the Mayo team. And I put him up because I found out that he was a Canadian. He actually trained at McGill, but then he went to do his fellowship down in the Mayo Clinic, and they kept him, and he had an illustrious career there. But this updated series, they now had the ability to measure insulin in about 23% of the patients, And they gave us our understanding of what insulinomas are all about that we still use today. They showed us that 90% were benign, that Whipple's triad was still the best provocative test to use in patients with that you're suspecting an insulinoma. And now John Service was telling us about insulin glucose ratios that we could use as a screening tool. Their preoperative localization was angiography, which was accurate in 91% of the time. And this is a quote from the paper: limited experience with CT scan, only 1 in 7 localized. CT probably will not be as useful as angiography in these patients. So it just shows you that technology also changed as we moved on. Now, I put this up, I know it's getting into the era of CTs and MRIs, but I put it up because it really then just demonstrates how important it is to study your patients and really look at the big picture as well. This is a paper that one of our former presidents, Dr. Jeff Thompson, presented at our millennial meeting in the UK, and that was on patients with what we called adult nistidoblastosis. And up to this time, we thought this only happened in neonates, but Jeff showed us that it could happen in adults that had this diffuse disease. So the Mayo Clinic became a center where patients that either were non-localized preoperatively or had diffuse disease, and continued to follow these patients and report on them. And 5 years later, they made this astute observation that that nistidoblastosis occurred at had an increased prevalence of 400-fold in patients that had gastric bypass surgery. So showing us that we as surgeons were creating a new disease, and that opened our eyes and more study on the physiology of the GI tract and the pancreas. So, what can we glean from this insulinoma story? Well, I hope you can see the value of collaborating with other disciplines. Insulin was not discovered by a sole person. It took a team to discover that. And I hope also you saw that it's that keen eye of observation. That's how Whipple came up with Whipple's triad. Okay, so let's go back in and look at another one. Let's look at the gastronoma story and the Zollinger-Ellison at the top. Now, I'm indebted to Chris Ellison, who, yes, is the son of Edwin Ellison of the Zollinger-Ellison's fame. And Chris really feels that this clinical scenario and vignette really is something that changed Zollinger's way of thinking, and ultimately the operation that he did that led to the discovery of the gastronoma. And the story is this: in January of 1954, Robert Zollinger did what he thought was the ultimate peptic ulcer operation. He did a truncal vagotomy and a radical gastrectomy in a 19-year-old that was having recurrent ulcer disease. And he actually filmed it. Because he wanted to he submitted it to the American College of Surgeons motion picture because he wanted to highlight this. Unfortunately, the patient recurred 10 days later, and he immediately said, well, I can't present this as the ultimate ulcer operation. So he wrote the head of the motion picture committee, who happened to be Jenkins. And when I say write, that means he put pen to paper, he wrote it, he put a stamp on it, and he put it in the mail. And Jenkins responded and he said, okay, we'll take your motion picture away. But he said, this reminds me a bit of a case I had: multiple ulcers and an islet cell tumor of the pancreas. Could your little girl have a touch of hyperinsulinemia? Because remember, at that time, they knew islet cell tumors made insulin. So he was wondering if that could also cause it. So they actually studied this 19-year-old and proved she did not have hyperinsulinemia. But he went on to then present this landmark paper in 1955 at the American Surgical. And this is just a picture from that article. This is the operation, and he filmed and where you can see a remnant of the stomach was left behind. She then underwent radiation to that remnant, continued to recur, and then he did the total gastrectomy. But he went and then looked at the pancreas. And I agree with Ellison that he was stimulated to look at the pancreas based on what Jensen said. And he found an islet cell tumor and metastatic lymph nodes. This was Ellison's patient that was presented. And this patient also under recurrent ulcers underwent a total gastrectomy. Unfortunately did not live, died 32 days or 34 days after surgery. But on autopsy, they found a small islet cell tumor in the pancreas. And these two cases were the premise of this article, of this presentation. So what did all these other 5 guys have to do with it? You know, we have Whipple, we have Dragstad of the vagotomy fame. Well, these were the 5 discussants of Zollinger's patients. And each and every one of them gets up and says, thank you, great case. I think I also have one, and talk about their clinical experience. And by the time this publication was published in 1955, there were 7 additional cases, so a total of 9 patients with recurrent peptic ulcer disease and islet cell tumors. And Zollinger postulated that glucagon, because the only other substance they knew the islet was making was insulin and glucagon, so he said glucagon or some other substance from the islet is exciting gastric secretion. And gastrin wasn't even isolated until 5 years later. Now, the term Zollinger-Ellison syndrome actually came from this gentleman, Ben Eisman, and he was a surgeon in Colorado. And he wrote a case report a year later, and he's the one that said we should call this Zollinger-Ellison syndrome. And I put up this picture from his case report, once again to sort of highlight what Dr. Wilson said, that once you operated on a patient, you operated on them for life. So he did an operation in 1943, and then February of 47, and then May of 47, and then 1955. But what happened here is that Eisman was actually in the audience at the American Surgical, and he heard Zollinger talk about this. So he immediately went home. He did a total gastrectomy with a colonic interposition graft, and he then did a distal pancreatectomy for a metastatic islet cell tumor of the pancreas. Interesting, if you read it, this was a 39-year-old male who was suffering from what was known at that time as functioning adenoma syndrome. He had a parathyroid adenoma, anterior pituitary, and he also then was found to have adenomas in the pancreas. Now, you go, well, that's 1956. MEN1 was described in 1954. Okay, but let's remember, for Eisman to know about MEN1, first he would have had to have subscribed to the American Journal of Medicine. Second, that journal would have had to have been delivered to his office, and he would have had to open it and read that article, because there wasn't a tweet, a blast, notification, landmark thing happening. So we have to give him credit. You know, there is going to be a bit of a delay. Now, the treatment of gastrinomas from 1955 into the 70s was really to go after the end organ, because there was no good treatment for ulcer disease. And H. pylori eradication, not even in something we were considering. So total gastrectomy was what was the operation of choice, even though it had a mortality of almost 15%. Now, this blue book is the very first surgical endocrinology textbook that we have, and it was edited by Stanley Friesen, one of our former presidents of this society. And he put together a bunch of clinical syndromes and had leaders from all over the world write the chapters. And the one on Zollinger-Ellison was written by Robert Zollinger. And he said, contrary to established surgical principles, it is desirable to leave the tumor behind and remove the stomach rather than perform a radical pancreatic resection. There may be temptation to remove a solitary islet cell tumor without total gastrectomy, but Zollinger admitted he had absolutely no experience in doing that. He always did the total gastrectomy. And probably combining a Whipple with a total gastrectomy, the mortality was probably too high. Later on in the chapter, he talks about there may be tumors in the submucosa of the duodenum. He felt that that was less than 10% of the time, but he commented there were some surgeons that were just excising this and doing a vagotomy. Well, you then go 12 years later when the second edition of Surgical Endocrinology comes out. Stanley Friesen now gets Norm Thompson, our inaugural president of this society, to help edit it with him. And now there's a new chapter in this textbook on what was Stanley Friesen wrote, which was called pseudo-Zollinger-Ellison, which is really G-cell hyperplasia. And Friesen then went to great lengths to try to then say what's important is that you then interpret the secretin stimulation test, because localization still remained a challenge. 40% of the time, they could not find the tumor. We still didn't have MRIs, there was no scintigraphy, no ultrasounds. Now, Stanley, Professor Friesen and Thompson, I know they were good friends. I also know they were both absolute gentlemen. And so at the end of each chapter, there's an editorial. So Norman wrote the editorial to Stanley's chapter on pseudo-Zollinger. And he goes, I think, Dr. Friesen could be right. Some of these patients could have G-cell hyperplasia, but I believe the missing gastronoma is in the duodenum, and they're small 3 millimeter, 2 millimeter lesions. And we know from some of the original early drawings that Norman did, because he always drew his operative reports, that he was opening the duodenum even when he found a large tumor in the pancreas. All right, so what's also happening at this time is now there's some medical management. H2 antagonist in 1975, proton pump inhibitors in the early 80s. And so true to NIH's format, they then had a prospective study where they were going to medically treat all patients with Zollinger-Ellison and not take them to the operating room. And you can see this was Robert Jensen, who is the endocrinologist, and the surgeon was Murray Brennan, one of our esteemed members of this society. And Murray presented this to the American Surgical, this prospective trial, in which 26 out of the 32 patients were treated with cimetidine management. And if you just read the abstract, never just read the abstract of an article, please, but if you just read the abstract, you'd get the impression that medical management was now the treatment. But what was so important is in the discussion, Dr. Brennan then had a very provocative thought. He said, well, maybe now we should be going back to oncological principles. Maybe it's now time for a staging laparotomy, because he still struggled with localization. And if you open the patient up and you find the tumor, and you can do an R0 resection, do that. If you open the patient up and you can't find a tumor, do a vagotomy and a pyloroplasty, and then that'll help with the medical management going forward. And so he threw the gauntlet down to the next generation, led by Jeff Norton. And Jeff Norton was one of our former vice presidents of this society, and two of our prominent members, Rich Alexander and Doug Fraker. These three probably have written the most on gastronomas in the last couple of decades. But what Jeff Norton taught us was that we should be doing surgery for sporadic disease, and that you had to open the duodenum, and showed that by opening the duodenum routinely, you increase the rate of finding the gastronoma from 76 to 98%. He also went on to show that there was a survival benefit in routine duodenotomies. Now, I want to just go back to this MEN1 bit, and for those that don't know, MEN1, so in 1953, Underlall, who was at the Mayo Clinic, described 8 patients, none of them related, that had multiple clustering of endocrine tumors, the pancreas, the parathyroid, and the pituitary. It was a year later that Paul Werner then presented a kindred and showed that there was actually a familial scenario here, and it was a syndrome that was likely coming from an autosomal and dominant gene. The interesting thing in this article, when you read it, he talked about how frequent peptic ulcer disease was in this kindred. So when we talk about multiple endocrine neoplasia, and who in this society really sort of led that charge, we all think of Professor Sam Wells. And so Sam Wells was trying to get as many patients that had this MEN1 syndrome to help try to find the gene. So he went to The Ohio State, and this is a vignette that Stu Wilson gave me, and he visited and screened all the patients they had that had Zollinger-Ellison syndrome. And the screening at that time is a calcium, a phosphate, and a PTH. And he then met Mary Jane. Mary Jane was the 19-year-old that Zollinger operated on. She's now in her 50s, and he proves that she has hyperparathyroidism. She undergoes a subtotal parathyroidectomy, and she lived to the age of 66, when she then died of a pulmonary embolus after undergoing a thoracotomy for, yes, a bronchial carcinoid. He also found, Sam Wells also found that her daughter was also positive. So what can we glean from this gastronoma story? Well, as general surgeons, we understand GI physiology, and when you combine that with the knowledge and understanding of endocrinology, that's a very powerful, and you need to be utilizing that in your own institutions. I think this also shows you the value of sharing complex patients with other colleagues. That is why we have an interesting case session later on today. That is why at the coffee breaks, you'll hear many of us going, hey, have you ever seen this? Or what are you doing with this? Because it stimulates understanding, growth, and new questions. Okay, so the last two, I only have 2 slides on each of them, so I'll go a little bit faster, but I do want to talk about them because they have another concept, a couple of concepts I wanted to talk about, but also both of them have a Dallas connection, and so we're here in Dallas, we should celebrate that. So let's look at the glucagonoma story. Now, glucagon was thought to be a contaminant from insulin. And it wasn't until Unger here in Dallas in 1963 proved that it was actually coming from the alpha cells, not the beta cells. Now, Hiram Polk took a patient to the operating room in 1963, I think, and he operated on her and found that she had metastatic pancreatic cancer. And McIver went on to publish this because she also had this unique rash, this unique necrotizing migratory erythematous rash that we would now recognize today, and reported it as a paraneoplastic phenomena from pancreatic cancer. But the patient was alive a year later, and that they thought, well, that's odd, because that's not what usually happens with adenocarcinoma. So he took her back to the operating room. He then resected the large tumor in her pancreas and debulked some of the liver lesions. And there was a temporary response to the skin rash, and she went on to live for another 3 years. So this concept of surgical debulking for palliation of endocrinopathies from functioning neuroendocrine tumors, this is the first time I saw somebody actually describing that. And that's a principle that we use today. Okay, the last one. What about Werner-Morrison syndrome and the VIPoma? Well, John Werner was an internal medicine resident from Duke. And he was attending a CPC round where they were presenting a man who died following a hemorrhoidectomy from profuse diarrhea, uremia, and hypokalemia. Now, on the autopsy findings, they said there was an incidental note of a small non-beta islet cell tumor in the pancreas, that it was of no consequences. And they listed the cause of death, chronic laxative abuse. Well, Werner's sitting there and he goes, I don't buy that. That's not why he died. And he turned to the guy that was beside him. And he happened to be sitting beside Ashton Morrison, who was a renowned pathologist at Duke, who also had an interest in how the kidney handled potassium. And Morrison agreed with him and said, no, I agree. I don't think that was the cause. There's something about the potassium. Now, it was just serendipitously that about a month or a month and a half later, that Werner was made aware of another case, a young man that was chronically coming into the emergency department with dehydration, but also and diarrhea, and had hypokalemia. So he tried to track him down. He found that he was actually admitted to an outside hospital and ultimately died. So they got an autopsy on that patient and showed there was a small islet cell tumor in the pancreas. So based on these two cases, they then reported it in 1959, or 8. Now we had a syndrome, and so here in Dallas, Jess Thompson, who's on the left, he went in, said, okay, you have watery diarrhea syndrome, went in thinking maybe I'll find an islet cell tumor. And lo and behold, he did. He then did a distal pancreatectomy, and the patient did well. But it wasn't until 1970 that SAD from Dallas actually isolated VIP. And it wasn't until another 10 years later that they actually said this was the cause of Werner Morrison syndrome. So what can we glean from this story? Well, I would say always expand your knowledge outside of surgical rounds. I loved going to endocrinology rounds on a weekly, monthly basis. Yes, I know more about apoprotein C and diabetes than I'll ever use in my practice, but just watching and listening to other disciplines look at a similar problem from a different lens just increases your knowledge and expertise. And I would say never accept surgical or medical dogma. So, in summary, I hope I have been able to meet my objectives, and I've illustrated to you the invaluable contributions that surgical endocrinologists played in our understanding of neuroendocrine tumors. You have a unique expertise being an endocrine surgeon, and so you must utilize it. I hope also you've seen the invaluable importance of collaborating with other disciplines within your institution. They say we all stand on the shoulders of the giants that have gone before us. And I've just been so fortunate to be able to stand on the shoulders of mentors like Dr. Stuart Wilson in this association. And so I would say for the younger generation, you should tap into that clinical knowledge and expertise that your mentors have. It may not be in the textbooks, so tap into that, because that may help answer the questions you're struggling with now and hopefully lead you to new questions that need to be answered. And for the more senior members in this association, I would say never hesitate to lift up and catapult the younger generation onto your shoulders. The future of endocrine surgery lies in this association, and the future of the AAES lies in the next generation of endocrine surgeons. And from my perspective, standing here, looking out, the future is very bright. So I'm going to leave you with one final quote, and this one Stu Wilson directed me to when he said, look up what Churchill had to say about studying the past. Churchill said, the farther backward you can look, the farther forward you can see. And with that, I want to thank you for the true honor and privilege of the podium today. Thank you.
That was outstanding. Did not disappoint. So, Janice, that was really great, and I learned many little tidbits I did not know. So you have to study history so you do not repeat the mistakes. I'm a big fan of that. The importance of us, the surgical endocrinologists, being a resource to our surgical colleagues and to our endocrinology colleagues. That we know that we're experts in multiple endocrine neoplasia. We know these things, and help our thoracic surgeons, our HPB surgeons. We may not be doing the big cases, but we know about the hormones. Very important. We help our general surgeons. We are participants in the multidisciplinary boards. We must continue to be knowledgeable about this topic. Even if we're not doing the pancreas cases. I really thank you for that. Thank you. Okay, so congratulations. I have a plaque for you. Janice, Pasieka.
Hey. Okay, thank you.
Okay, so we have a 45-minute break now before the next scientific session. Head out the door to view the posters, please, and visit our exhibitors. And when you return from the break, we will hear from our next distinguished moderator, Dr. Mary Beth Hughes. Thank you very much.